Thank you so much for the kind introduction, Dr. Satapathy. And it's really my pleasure and honor to present to all of you today on the current status and future prospects for AI in liver transplantation. So I actually, as Dr. Satapathy mentioned, I co-lead our Transplant AI initiative at the Ajmera Transplant Center. And these are very exciting times, as you know, for AI in healthcare in general. And so it's really wonderful to be, collaborating with computer scientists within our Toronto ecosystem to drive such efforts in transplantation. I also serve as partnerships and engagement lead for the Temerity Center for AI and Research and Education in Medicine. So this is a large network that is based in Toronto, but encompasses over 24 centers across Canada, over 24 institutions across Canada to develop and deploy machine learning algorithms into healthcare. So this really is the time for AI assessment and deployment with vigilance. So I'll talk to you a bit about liver transplantation efforts and how this really fits into the broader scope of things. I don't have any specific disclosures or conflicts of interest with respect to this specific presentation. So I'll start off with an outline of what is machine learning and why we should be considering machine learning in liver transplantation. I'll get into some case studies in liver transplantation that my group has been evaluating and working to deploy. So I'll talk to you about the practicalities of clinical deployment. And additionally, as Dr. Satapathy mentioned, I have a background in bioinformatics and molecular biology. So really my greater interest is to ultimately integrate the various types of data that we have to personalize the care of transplant recipients. And I think, my hope is that overall you will take from this lessons and say inspiration for your own work and potential applications in your own work. So I'll start off with what is machine learning and what is artificial intelligence. So I think, say a year ago when I was giving this talk, this would have been a less well-known topic. But now that generative AI and large language models have really taken the world by storm with ChatGPT and other such models, natural language processing, there's a lot of awareness because we are now getting surrounded by AI in various spheres of our world. I would say that healthcare has been somewhat slower in the evaluation and adoption of AI solutions. And I think there are different reasons for that that we can get into in the discussion as well. I think I'd be very interested in hearing everyone's thoughts and perspectives on this. So AI, as many of you are probably aware already, it combines various traits: learning, reasoning, problem solving, etc. And it's basically intelligence demonstrated by machines. And so there are many valid definitions, but ultimately this represents computer systems that will use information and act in a goal-directed manner. And so if you look at the, say, figure to the right here, you will see that there are so many different potential applications in the realm of medicine and healthcare. So particularly now with, say, generative adversarial neural networks or these ChatGPT or generative AI solutions, you have this ability to say ask certain questions of such generative AI solutions, and this system or this computer system will basically sift through the entire say, publicly available literature to generate an answer. And if you haven't actually tested out such a solution, I would encourage you to test it out to see how well such solutions are able to respond to, say, standard hepatology questions. I think for the most part, these will be appropriately answered. Of course, the limitations are that such generative AI solutions like ChatGPT will only have access to the publicly available literature. And so, say, literature or content that requires payment will not be accessible. So this is why, for, say, certain more specialized pieces of information, ChatGPT will be unlikely to answer accurately because it doesn't have access to that, payment protected information. And so, ChatGPT, for example, is able to perform very well on standard questions from the USMLE. But if you look at, say, GI board exams, that represents much more specialized literature that such a generative AI solution is unable to answer effectively, and in fact, even can hallucinate the answers, meaning that it may offer answers that are inaccurate. And this can mislead the user. So one has to be also very careful, although very exciting at this point. One also has to be a bit, careful about the acceptance of such information, which is something we can discuss further at the end of the presentation. So overall, there are various different applications possible in medicine. And I think, particularly the areas where images have been, a standard part of practice, including radiology and pathology. These are highly amenable to AI solutions and AI co-pilots, robotics, so AI-assisted surgery, anticipating who are patients who will require transfer to ICU. So, for example, EPIC, our electronic medical record system, in my institution, and I know that this is widely available at several institutions worldwide, is able to predict those patients who are at risk of deterioration and needing to go to the ICU. So there are, say, longitudinal changes in physiological parameters that could then inform or predict a higher risk of deterioration in the coming few hours. And such an alert can then help physicians to, prevent such deterioration. So there are multiple applications, and I think, this is very exciting at this time. There's so many different applications that are being evaluated and studied, and, the larger scale transferability of such solutions is very important to assess as well. So, okay, and then what is machine learning? Well, machine learning is actually a subset of artificial intelligence. It is a field of AI that allows software applications to become more accurate at generating predictive models without being explicitly programmed. And this allows for detection of hidden patterns and interrelationships within large data sets. Deep machine learning algorithms are a subtype of machine learning algorithms, as are neural networks. So this is just to kind of situate you in terms of the lingo that is used in this space. What is the pipeline for machine learning? Well, you have collection and processing of inputs, choosing an algorithm that can map the input to the output, collecting and processing the outputs, and finally training and optimizing the algorithm until the predicted and true outputs are similar. And so you want to work towards optimizing until these two outputs are similar. How does machine learning compare to traditional biostatistics? So a standard clinical risk assessment model will assume that a risk factor is related in a linear fashion to clinical outcomes. And so what machine learning tools can do is better incorporate multiple variables, so hundreds of variables, and identify more nuanced relationships between those risk factors as well as the outcomes. And these algorithms can help you understand and learn from existing data to find novel patterns. So this is a nice figure that actually represents, on the one hand, standard biostatistical models, which are also going to be computationally cheaper to run, versus the black box machine learning models. And these allow us to decipher and understand predictions based on nonlinear relationships as well as longitudinal data. However, this is computationally expensive and may require days of processor time to build models. Now, I think there's so much progress that is happening in AI, such that even the coding in future could partially be done by such AI solutions. So, which is really something very impressive as a development. There are three main paradigms of machine learning. So supervised learning, which is predicting labels from data. So if you have, say, a binary outcome, yes or no, then this is where supervised machine learning tools, or those conventional machine learning tools, would be used. And so, for example, if you wanted to predict pneumonia from a chest X-ray, then a supervised machine learning solution would be appropriate. Unsupervised learning, so learning representations of the data. And this is so if you have multiple potential categories and you don't actually know what those categories are going to be. So really, this is an unsupervised approach to discover subtypes. So for example, in this, you have microarray data, so gene expression array data, and you want to discover certain subtypes of breast cancer. And then finally, there's reinforcement learning, which is dynamic decision making using data. And so over time, as there's new data that's getting fed into the algorithm, then there's new predictions that can be made based on, so for example, if you have real-time drug dosing practices, then you want to understand what those changes in drug dosing are doing in terms of outcome, and then kind of feed that back. So what is the outcome? You feed it back, and then so the model will continue to learn as to what is the optimal drug dosing to optimize the treatment course for the individual patient. So this is a figure that we published in a review in Hepatology International last year. And so basically you have unsupervised as well as supervised machine learning tools. These are the different types of models that one can consider using for such questions or tasks. So why machine learning in liver transplantation? So the reality is that in hepatology and in transplantation, there's so many different factors that are going to affect transplant pathology and outcomes. So, a variety of clinical factors, such as sex, ethnicity, age, genetics, environmental exposures, body mass index, lifestyle, exposures, diabetes, immunosuppression. So there's so many different factors that are affecting the outcome of a patient, of an individual patient. And as well as practitioners of hepatology, we are often assimilating and integrating in our own minds complex nonlinear patterns in liver enzymes, liver function tests, and various other laboratory tests to then inform our own personalized predictions for a given patient. So the reality is that one size doesn't fit all. So if you look at, say, consensus guidelines, they're going to provide you what is appropriate to consider for the overall population, but they aren't actually providing you guidance for a specific patient. It's not possible to do that based on the current consensus guidelines in different areas of medicine. So in clinical practice, the reality is that each of us is on a daily basis, when we see a given patient in front of us, we're considering all these changes that are occurring over time to then inform our own personalized predictions. So for example, if I see a young patient transplanted for autoimmune liver disease, and they have an elevation in their liver enzymes with an ALT greater than AST pattern. Their alkaline phosphatase may be elevated, bilirubin is normal. Then I'd say, well, and then additionally, maybe I tapered their immunosuppression a few months ago. Maybe they weren't tolerating their tacrolimus level so much. So then I decided to come down just a bit on that trough level. And now they have a flare up in their liver enzymes. So then in my head, I'm thinking, well, this is most likely an episode of rejection. And then I will act according to that. So the reality is that in liver practice, and this is true in chronic liver disease management in general, you have your own sort of pretest personalized probability for a given patient in front of you based on a variety of like a constellation of blood test results, clinical parameters, and changes in those tests over time, because all of that is highly informative to generating personalized predictions. So the reality is that we're doing this in clinical practice, and say an expert transplant hepatologist will have seen several patients, maybe they're 20 years into practice and they've seen several hundred patients, but a more junior transplant hepatologist will have seen less. So I think ultimately the idea is that, say, a machine learning algorithm could learn from many, many more cases to then provide help or serve as a co-pilot to a physician's, say, expertise, or, kind of guide the physician in a certain direction in terms of further diagnostic investigations or therapy. And there are various other types of data that all of us are collecting as well, in addition to the standard clinical and laboratory parameters, including, say, electronic health record data, imaging technology, histology, clinical sensors, wearables, and omics data, so molecular data. And so all of these represent a wealth of data that can then offer us personalized predictions for a given patient. And so this figure to the right is taken from a paper that we published in NPJ Digital Medicine, and it's a review on the applications of machine learning in transplantation. Additionally, we recently published in Journal of Hepatology a review on machine learning in liver transplantation, and I'd refer you to that paper as well. It was published in June 2023, so this year. So in terms of applications in transplantation, specifically, we have waitlist prioritization, we have applications in donor-recipient matching, as well as prediction of outcomes after transplantation, as broad categories, really. But then there are multiple questions, and really, this ability to take into account these longitudinal changes in parameters, I think, is highly informative for these personalized predictions. So this is a figure just representing the opportunity for AI in liver transplantation. And I've had the good fortune of working with, as I mentioned, computer science professors in the Toronto ecosystem, really to drive efforts across the spectrum from pre to post-transplant. And so, as I said, there's so much dynamics wherever you are on this spectrum, particularly on the wait list. So a patient enters the wait list, and there's going to be dynamics on that wait list. So, for example, if a patient has an infection, maybe they have a MELD sodium of 13, so not very high, but they are suffering in their day-to-day life with requirement for regular paracenteses, et cetera. And then suddenly they develop an infection that really then precipitates their status. So there will be a rapid decline, and maybe the liver gets stressed, but then also takes the kidneys, the lungs, and the brain along with it. And so they go into acute on chronic liver failure. The reality is that their mortality is not going to be best reflected by just that MELD sodium. It's going to be informed also by this rapid deterioration in their liver status and their overall status. And additionally, maybe this is a 65-year-old with diabetes, chronic kidney disease at baseline, a certain degree of sarcopenia. And so there are various other factors that are going to impact their ability to withstand and live through that acute on chronic liver failure. And so once they're reactivated on the wait list, their MELD sodium is going to be higher. So say they survive this ACLF, and they are at a higher MELD sodium. Well, the reality is that it's not just that MELD sodium, it's that trajectory over time that's going to inform their outcome on the wait list. So they probably need more prompt access to liver transplantation. Post-transplant, additionally, there's various causes of death that are important in transplant recipients, and I'll get into that a bit in a bit. But certainly there are various outcomes that are going to be predicated on a variety of factors, not just one or two, but a variety of factors. So now we'll get into some case studies in liver transplantation. So as I mentioned, the MELD sodium is what we have been using to prioritize patients on the waiting list. And certainly this had an impact in terms of significantly decreasing wait list mortality. Now, as you know, the bilirubin is underweighted in this as compared to the INR and creatinine. And this model was trained on a hepatitis C predominant population. So overall, waitlist mortality has significantly been reduced, but there are certain subpopulations of patients who are not well served by this particular system. Now, over time, there's been a shift in the underlying patient cohort. So hepatitis C obviously is no longer a dominant indication worldwide, given the ability for us to cure hepatitis C for the most part, for the vast, vast majority of patients. And so now in North America and Canada, where I am, alcoholic liver disease, as well as MASH, non-alcoholic steatohepatitis, as it was otherwise called, previously called. So these have become the dominant indications. Additionally, HCC, so hepatocellular carcinoma, is no longer really an exception. It's actually a dominant indication for transplantation in our jurisdiction, representing a high percentage of patients. So we have 38% of our patients who are being listed for exception point indications. So really, those exception point indications are no longer really exceptional. So there's been so many changes in the type of patient we are transplanting with various comorbidities, so an older population. And so, there's so much that one needs to consider when determining candidacy for transplant, as well as ultimately, whether someone is going to benefit as opposed to the risks. This is a linear functional form. And additionally, as I mentioned, it unfortunately disadvantages, and we found over time that it disadvantages female patients as well as patients with cholestatic liver disease. So we in fact published a paper a few years ago in JAMA Surgery demonstrating that in our jurisdiction, certainly access to living donor liver transplantation is important to have equity on the wait list for women, because otherwise they are significantly disadvantaged in our jurisdiction if they have only access to deceased donor transplantation. And this was work of first author Ravi Karnam, was a transplant hepatology graduate from our program, and now a hepatologist in India. So certainly that is one paper that has demonstrated to us that certainly we need to change the system. An additional paper we have recently published is demonstrating the same for PSC patients, who unfortunately also are not well served by our current system, because their bilirubin is in fact the dominant indicator of severity of disease. And unfortunately, this is underweighted in the MELD system. And so, this again was work driven by a transplant hepatology graduate from our program, Fernanda Onofrio, who published this paper in Hepatology Communication. So this really now, serves as an impetus to us to try to better serve these patients who are not well served at the current time. Now, certainly with MELD 3.0, there are some positive steps in helping women on the wait list to be better served. But I think there are certainly things we can do much better with the advent of machine learning tools at our disposal, and also our ability to create new machine learning methods that are specifically designed for this problem. So that's another thing I would say is a take home from this presentation, in that I think, working closely with computer scientists has kind of opened my eyes to how one can develop solutions that are really created for a specific clinical question. So the issue is that often off-the-shelf machine learning tools may be evaluated to address a specific question, and certainly we do that. But then, with the expertise of computer scientists who then understand the clinical problem based on this crosstalk, so we meet regularly, they also understand the clinical problem very well, and then are able to design methods that are really appropriately suited, or ideally suited for the clinical problem, such that performance is much better enhanced. So this is a study wherein we looked at over 120,000 patients listed for transplant in the US, adult patients with decompensated cirrhosis, and several static and time varying features per patient. And this is work driven by my co-supervised PhD student, Michael Cooper, with Rahul Krishnan, who is an assistant professor in computer science at the University of Toronto. And here we looked at various types of models. So the Cox-PH model basically assumes linear correlation to derive a patient risk score. And in our work, we have modified a particular deep learning version of the Cox proportional hazards model to add certain covariates to each particular time point, accounting for velocity as well as acceleration, so rates of change in the covariates over time, in the variables over time. And then there is an additional function that we've added basically to optimize performance. And this is really based on the consideration of unique characteristics of liver transplant waitlist patients. So here you have this consideration of all these different variables, this representation of what this means, so interrelationships and longitudinal changes, to then inform a more optimized patient risk score. And so what we have found really is that our score, our prioritization system, is able to better prioritize patients on the waiting list by considering all these changes over time, including the rates of change in these several parameters. And what we have also determined is that certain populations that are underserved by the current system would now be better served by this particular system. So now we have also looked, so this is a specific example of a female PBC patient who is on the waiting list and would have been better served with our system as compared to the MELD sodium. So, and then we've also looked at simulation of allocation outcomes using this model and determined that pre-transplant mortality would be rendered equivalent for women versus men with the system. There is additional ongoing work looking at the transferability of this model to our UHN data, and we actually do have funding from our Canadian Institutes of Health Research to drive more national efforts to look at improving our prioritization system. Now I'll get into post-transplant. So just shifting gears into the post-transplant realm. So as many of you know, the median survival of liver transplant recipients leaves, say, a lot to be desired. So given that they unfortunately don't live as optimally as we would want. So although certainly short-term outcomes, so 1 year survival has dramatically improved in the last 30 years. We know that long-term outcomes beyond a year have not improved in the last 30 years. And this was nicely put together in the Annals of Surgery a few years ago, demonstrating that the long-term outcomes beyond the first year have not improved. And this is due to various complications over time in transplant recipients. Certainly, our patients go into transplant with existing comorbidities and lifelong immunosuppression. But what happens is there seems to be accelerated disease, so including a heightened incidence of cancer due to the presence of immunosuppression, cardiometabolic disease, as well as infection. And in terms of Canadian liver transplant recipients, what we've determined is that they, in fact, live 20 years less than the Canadian life expectancy. So we could actually do a lot better to improve the quality and quantity of life of our patients. Right now, the care of liver transplant recipients is really based on limited evidence, retrospective, observational evidence. There are many different, say, epidemiologic studies out there, single center, rarely multi-center, rarely any RCTs in this area. So, and you can forget double-blind randomized control trials, because those also have been pretty much limited and non-existent, I would say, in the last several years. So what can we do to change this and turn transplant into a cure? Because certainly we want to help optimize our patients' survival in the long term. So we published this paper a few years ago in Lancet Digital Health, looking at the long-term mortality risk stratification of liver transplant recipients. And this was a nice collaboration with Bo Wang, who's a computer science professor at the University of Toronto and at the University Health Network. And it was driven by two trainees. So Oswald Nitsky, a computer science trainee, as well as a clinical trainee, Amir Ajay. So basically, they were the main drivers of this work. And it was a nice, say, crosstalk between our two teams, the computer science and the clinical teams, to really drive this work forward. And what we did here was to attempt to predict mortality due to long-term complications after liver transplantation. So we evaluated various deep machine learning algorithms to predict mortality post-transplant at various times post-transplant. And we incorporated longitudinal data, classified patients into major risk categories. The idea was to make a more personalized risk calculator for managing long-term transplant care that could be used at each follow-up visit. So say we see patients on an annual basis beyond a year post-transplant, the frequency of follow-up is diminished, and really beyond 2 years, we see patients on an annual basis. So what could we do to optimize their long-term outcomes? Rather than using a one-size-fits-all approach, which is what we have been using traditionally, with some, changes based on experience. So each person will have their own, say, assessment based on maybe symptoms of a patient or progressive deterioration in their kidney function due to the calcineurin inhibitor. So there's going to be different tweaks and changes that will occur over time. But what could we do to really provide more objective assessment, as well as guidance as a co-pilot, really, to liver transplant physicians or physicians taking care of liver transplant patients? Additionally, I would say we will provide certain guidance to patients based on our own intuition, So for example, we may say, well, we need to get better control of your diabetes, or you may need to work on decreasing your body mass index so as to decrease your probability of cardiometabolic outcome. Now, when we tell that to patients, we're not providing any tangible prediction and tangible changes that, say, modifying these risk factors would have. So I think, this is where machine learning tools can be very interesting and important to provide such tangible, predictions, as well as provide this to empower patients in their own care. So this is what our reasoning was for this particular project. So we trained our algorithms on data from liver transplant recipients who had long-term follow-up. And so we looked at annual follow-up visits in over 65,000 patients, looked at 267 clinical variables, and looked at predicting 5 overall outcomes. So overall survival, death by graft failure, infection, cardiac event, and cancer, and 1-year and 5-year outlooks were predicted from each given visit. So for example, if you see a patient at 4 years post-transplant, you can then give them a 1-year and 5-year outlook from that given point in time. So our best performing model was a deep learning model called Transformer, and it had an overall survival AUC of 0.774, cardiac, graft failure, cancer, infection of 0.804 to 0.814, and 5-year ROC is presented here. This is in comparison to an advanced biostatistical assessment with logistic regression, which was lesser performing. We then cross-validated in our UHN data set, and this actually validated quite well in our UHN data set. So we looked at longitudinal data, again, from our UHN patient population, so tested in over 4,000 liver transplant recipients who had long-term follow-up, and we were able to achieve comparable area under the curve performance. Overall, we then performed Shapley analysis to have some interpretability to our algorithms' predictions, and in the Scientific Registry of Transplant Recipients, these were the top 10 ranked features. And then these were the top 10 in the UHN data set. So some of these are modifiable, others are non-modifiable. But what's interesting here is that you could generate such similar predictions. So now I'll tell you a bit about what we're doing in terms of efforts towards clinical deployment of this particular algorithm. So this is in collaboration with the chief data scientist at UHN, Mike Brudno, and his team, a student, as Sophie Liu, as well as Peter Maximowski, who's a data engineer. And they are facilitating the front end as well as back end to permit clinical deployment. And we're actually very close to deployment of this solution. So the idea is to have from EPIC, or EMR, or Electronic Medical Record System, the flow of data externally to Clarity, and then have that data flow back into our dashboard for personalized predictions of an individual patient. So what you can envision is that we have within EPIC this particular patient's data. This is just an example patient, not a real person. Basically, then have all of their data displayed here, and then this particular, deployed second window then will also give us predictions for this given patient of 1-year and 5-year outcome. And then what are the different features that are increasing or decreasing that probability for that given patient? And again, this is just an example for you. And in the end, what we can say is for this given patient, if we were to modify their sirolimus trough level by this percentage, what kind of prediction would one anticipate for their probability of cardiovascular outcome in the next 5 years. Additionally, what are the other, say, modifiable and non-modifiable factors that could then affect their long-term outcome? So I think this is where we also have a patient partner who is actively involved in this deployment effort and is providing us guidance in terms of the patient-facing dashboard that we're developing as well. And, in this regard, I think we can really empower patients in their care, because right now they don't have that tangible sense of what their future looks like. So we can provide that to them. Of course, these predictions are not 100%. One can, never predict 100% in the future. But I think, providing some such more tangible milestones or goals to achieve, I think will be very helpful for our patients as well. So these are our deployment goals. We are integrating this dashboard, which we call Dynacomp, into the liver transplant clinic, using SHAP analysis to obtain these modifiable ranked features. And we will then evaluate impact by patient outcomes and patient comfort with AI-guided care, as well as conduct qualitative interviews of physicians to refine these dashboards and to prepare for deployment beyond UHN. So we do have, we're very thankful for support from our Ajmera Transplant Center executive to develop and deploy such solutions. In fact, we're doing this across transplant programs. So we are working very closely with the medical director of lung transplant and helping others, including in transplant ID and kidney transplant, as well as pancreas, to develop machine learning solutions that could then be nicely deployed and assessed across our transplant center to really kind of develop that capacity and lead in terms of machine learning integration. And then, as I mentioned, there are national efforts through our Canadian Donation and Transplant Research Program as well. So we're very fortunate to have these kinds of networks and alliances to permit assessment and validation of such machine learning tools with care, I would say. So we want to also be very careful that any sort of machine learning solution is to have a positive impact and not an adverse impact. So really, we need to be cautious in our approach to deployment, but I would say that these tools are going to be co-pilots in the care as opposed to the pilots. This is another paper that so moving on to graft fibrosis or fibrosis, liver fibrosis. So this is a model that we developed in close collaboration with Anna Goldenberg, who's a computer scientist at the SickKids Hospital in Toronto. And this was driven by Soren Sarvastani, who was an engineering student, actually, undergraduate engineering student. And he developed this particular algorithm that was an ensemble machine learning algorithm that took into account various types of data to predict the presence of advanced fibrosis. So stage 2 fibrosis or greater in a given patient. This had very good performance, actually, that was equivalent to expert readers. And this work was published in Lancet Digital Health last year. We then used this as inspiration for work in the post-transplant arena. And so here, this was work driven by a postdoctoral fellow in computer science, who is now an assistant professor in biostatistics, Divya Sharma, along with Amir Aji, who is my clinical research fellow, and co-supervised by Wei Zhu, biostatistician in our at UHN. So we developed this deep learning framework for dynamic diagnosis of graft fibrosis after liver transplantation using longitudinal data. And using liver biopsy as the gold standard for diagnosis of advanced graft fibrosis, so stage 2 or greater graft fibrosis. And Divya actually developed this new method, which was specifically suited to this clinical question, where she fine-tuned and modified a standard deep machine learning methodology called long short-term memory network. So this integrates longitudinal changes in data in several variables, and she modified it to upweight the cases versus the controls and help the algorithm train much more on the cases so that predictions could be enhanced in terms of diagnosis of graft fibrosis. So the performance of this weighted LSTM algorithm was a very nice AUC, quite good AUC of 0.798 with sensitivity of 78%, specificity of 81, and 100% determinants. And this was in comparison to FIB4 and APRI, which are the conventional biomarkers for assessment of fibrosis. And the top ranked features here to provide interpretability to the prediction of this algorithm, these were the several ranked features that predicted performance of this algorithm. Several parameters that one would expect, and you can anticipate doing the same for an individual patient. So, for example, in the next slide, what is it that a clinician would see? Well, they would see these various parameters and longitudinal changes in those parameters, and say that the prediction provides a probability, 100% probability of this patient having significant fibrosis, so advanced fibrosis, either F2 to F2, F3, or F4. So then you then have a list of ranked features that predict that advanced fibrosis, and you can then act upon certain features to then modify the trajectory, the future trajectory of that patient. So you want to try to optimize that trajectory and prevent further progression of graft fibrosis. This would probably also prompt you to do a liver biopsy so that you can optimally modify the person's immunosuppression. Now, additionally, I'll conclude now with talking about molecular data. So as I mentioned, my group also is integrating molecular data along with clinical and laboratory data. So we have this particular interest given the expertise of some of the members of my team in this regard. As I mentioned, you have different types of ML tools that can be used for predictions. And certainly in cancer, people have been very active in integrating clinical and omics data for personalized predictions in patients, as you can see, in terms of survival probability and potential therapeutic targets and so on. So in the liver transplant arena, we certainly have need for integration of omics and clinical data to personalized prediction. So, this is a project that was supported by the Canadian Society of Transplantation. And what we were interested in was the problem of elevated liver enzymes in liver transplant recipients. So there are various reasons for elevated liver enzymes in patients post-transplant, and normally the liver biopsy will be the gold standard for diagnosis. However, this is invasive and can be delayed very often if not urgently indicated. And additionally, serial such biopsies are going to be difficult to perform, given the risks associated. So the reality is that, a physician will have a hunch based on patient profile and test patterns. As I mentioned earlier, this is a patient example of a young patient with elevated liver enzymes. And in this pattern of liver enzymes, this is going to be most likely to be T-cell mediated rejection. So we have actually looked into developing a machine learning algorithm to predict what pathology is present based on certain patterns in the tests over time prior to the biopsy, changes in immunosuppression, etc. And this is to inform personalized predictions of graft pathology. Now, the reality is that biopsy may not be readily available, so having such a clinical decision support tool would be very helpful in guiding physicians. So one has to be very careful not to administer the inappropriate therapy. So, for example, if there is a viral infection, such as hepatitis E or herpes, you don't want to be administering steroids for suspected rejection when that is completely inappropriate and could actually result in death. So this could be unsafe and there's a significant risk of adverse outcomes. So what can we do to make things safer for our patients? So, first of all, we did develop a machine learning algorithm trained on clinical and laboratory data to identify graft pathology. And the idea beyond that was to add on omics data, so methylation patterns on circulating DNA, to further refine these predictions. And so we looked at, first of all, over 7,000 graft biopsies performed at UHN, longitudinal changes in parameters over the week preceding biopsy. Recipients were divided based on histologic diagnosis, including the following. Recurrent hepatitis C is obviously out the window, very fortunately, but the other complications are also listed here. Our machine learning algorithm was able to predict, so we evaluated different ML algorithms, including artificial neural networks, which was the best performing model, and achieved an AUC of 0.866 for prediction of graft pathology. And you can see that here that across different graft pathologies, it performed variably, but was particularly effective in certain pathologies, including biliary complications and alloimmune hepatitis, as well as NASH. So overall, this algorithm was pretty effective at prediction, and we're now performing some external validation of this algorithm. So this is one particular algorithm that we developed, and these were the top predictive models, top predictive variables for these different graft pathologies. Now, we then added on, so in a subset of patients, we looked at patients on whom we had plasma samples to then look at methylation patterns on circulating DNA. And this was in close collaboration with Daniel de Carvalho, who has developed a very unique assay called cfme dipsyq, wherein there's a very nice pipeline to look at methylation patterns on a very small amount of circulating DNA. This assay was published in Nature in 2018, and we have been working closely with his team to look at this particular problem in the transplant population. So his assay was originally developed to screen for cancer in patients at risk. And we are now looking at this in the setting of liver transplant and liver pathology in general. So we performed a pilot study in patients with NASH. So 11 liver transplant recipients versus 13 controls, and looked at the differentially methylated patterns on genes, and identified several DMRs in patients with NASH versus controls, and identified the types of processes and pathways associated with these differentially methylated regions. So lipid metabolism with lipolysis function was particularly upregulated in liver transplant recipients with NASH. And we also looked at patients with acute cellular rejection or T-cell mediated rejection, and identified PDGF signaling, as well as some other inflammatory pathways that were particularly differentially methylated in these patients. So in the end, we then integrated that methylation pattern data along with clinical variables as well as laboratory variables to generate predictions of diagnosis, graft pathology diagnosis, and came up with a very nice accuracy, of 0.95 for the TCMR, so T-cell mediated rejection or acute cellular rejection versus NASH with 82% accuracy. And so I think this is very exciting and, a way for us to bring together the expertise in machine learning, integrating clinical as well as omics data. So overall, this is really my vision for the future of AI in liver transplantation. As I mentioned, there's so many dynamics on the wait list. There's the donor recipient matching considerations that are quite unique, and also subject to really subjective decisions. And so we want to bring more objectivity to such allocation decisions, and ultimately post-transplant outcome predictions can be personalized using such an approach, taking into consideration longitudinal changes in data and patterns in the data to enable modification and optimization of post-transplant outcomes. So I hope I've convinced you that there's a lot of potential for machine learning models in liver disease and transplantation overall. I think ML models have the ability to become more accurate at predictions over time without being explicitly programmed. There is certainly a lot of advantage to using such models by really their potential to account for nonlinear hidden relationships. These are particularly well suited, I think, for the complexity and pattern recognition problems in hepatology. This will provide us with the ability to provide personalized predictions for patients and really engage them in their own care. There's this ability to integrate different data types, including omics. I think the limitations, certainly there are limitations, and we will need to, in the next years, evaluate generalizability of such algorithms. They are certainly difficult to interpret, and there is this need to educate and create trust in the decisions and predictions provided by such machine learning models. So certainly the next frontier is clinical deployment of these algorithms to really evaluate their ability to predict accurately and optimize outcomes. And so I'd like to conclude by acknowledging my research team. It's really an enthusiastic and excellent research team, including machine learning postdoctoral fellows and an analyst. I have also people in the sort of bioinformatics arena and wet lab. And these are our key collaborators who have really provided a lot of, say, learning opportunities and crosstalk for all of us to learn from each other and optimize outcomes in the liver transplant population. I'd like to acknowledge our funding sources, and like to thank Dr. Satapathy for the kind invitation to present today. I welcome your questions and happy to start the discussion.